All right, well, it's the top of the hour, so let's go ahead and get started. Good morning, good afternoon, good evening, everywhere in the world where you may be today. Thank you so much for joining us for our third live case discussion in our complex lower extremity trauma series. Today we'll be talking about Pilon fractures. So just a quick reminder for everybody, we do have the ability to have translated captions available. So if English is not your first language, you can go to the captions option and select the language that you would like to see the closed captions in. Hopefully that will be helpful to everyone. So today's objectives, as usual, improve participants' knowledge, foster international discussion, and of course, motivate and support the younger generations of surgeons globally. So I'm very grateful to be the course chair. I'm joined today by Shravya Challa and Haley Daniel, who will be the course moderators for today's session. And of course, thank you so much to our incredible HGOC and SONA organizing team who make all of this possible. There's so much organization that goes into all of this, and this would not be possible without this incredible team. So thank you to each and every one of them. Really incredible work. So today we're joined by 5 case presenters, Dr. Subhash Regmi, Dr. Sarthak Nepal, and Dr. Fabio Rodriguez, and then Dr. Fasi Shahab and Dr. Fernando Raduan. We have fantastic case discussants as well, faculty from all over the world, Paul and Naresh, who you'll recognize from our previous sessions, Dr. Bonnie Chen, Dr. Daman Jha, who's also representing our partner organization for this session, the Nepali Orthopaedic Association Foot and Ankle Subcommittee. We're very grateful for Dr. Daman, Dr. Subhash, and Dr. Sarthak's presence today and for their participation from that organization. Dr. Justin, Isaac, and Nishant, Ken Rodriguez, Dave Shear, Mai Nguyen, and Mike Weaver, Jack Wickstead, and Pierre-Marie Woolley. So let's get right into it. Today's agenda, after this quick introduction, we'll dive straight into the first case presentation by Dr. Subhash Regmi, then Dr. Sarthak Nepal, then Dr. Fabio Rodriguez. And then at the end, we'll have Dr. Fasi Shahab and Dr. Fernando Raduan share their different approaches for performing primary fusion in the setting of a Pilon fracture, which I think will be an interesting end to the discussion today. All right, well, without further ado, I'll hand it over to Dr. Shravya Challa and also to Dr. Subhash, who can go ahead and share his slides. Thank you so much.
Just as we're getting slides up for organizing the discussion, we'll just have the presenter fully complete their presentation. And then if you have comments, faculty, or questions from anyone, just raise your hand through the reactions, and we'll just call on each of the ones that we're seeing together. Dr. Daniel is also here with me to moderate the session. So we'll kind of go back and forth asking the questions as we see them, okay? All right.
So am I audible?
Yes, you are.
So good evening to everyone from here. I'm Dr. Subhash Regmi from BNB Hospital, Kathmandu. I would like to thank the organizers and NOA Foot and Ankle Subcommittee for providing me this opportunity. Today I'm going to present a case on partial articular tibial Pilon fractures, which was managed in a single stage manner. So it was a 48-year-old gentleman presented following road traffic accident who sustained injury over the left limb. He was a non-alcoholic, occasional smoker, and he has no known comorbidities. There was swelling present, and fracture blisters was there, which was serous. And there was no other associated injuries. Distal neurovascular system was intact and no sign of compartment syndrome. The plain radiograph is like this, which suggested the involvement of medial column, anterior intermediate column, and lateral column of the ankle. And we also obtained a CT scan, which suggested the same. There was no involvement of the intermediate posterior column or posterior malleolus. So this was a 3D reconstruction image. This is not maybe not so clear visible, but it suggests that there was no involvement of the posterior malleolus. We waited for the soft tissue to get better, and he was operated on the 6th day of admission. And it was we opted to go with the anterior lateral approach of the ankle to fix both the fibula as well as the tibial pilon. And the reduction was the articular reduction was directly visualized and done with using a joysticking method with using K wires. And then medial malleolus was fixed with a separate small anterior medial incision and with that orifice with TVW. So it was an immediate post-operative X-ray, which was acceptable articular reduction, and the implant positions were better, and there was no post-operative wound complication. And patient was discharged on the 4th post-operative day, and he was the ankle range of motion was started on the 1st post-operative day. However, the weight bearing was started only after 6 weeks following this X-ray evaluation. We suggest that there was no implant loosening or any sign of loss of the collapse of the articular element. However, we observed progressive collapse of the subchondral bone in the subsequent follow-up on 6 months. Patient was walking without any discomfort at that period of time. However, in the 1-year follow-up, he started developing mild pain, but still he was walking and performing daily living without any major functional limitations. However, the radiograph showed that there was a collapse of the subchondral element, and there was some degree of post-traumatic arthritis, as well as there was a stellar tilt with some degree of varus. We have appreciated that in the X-ray. However, patient was functionally did not have any problem with walking and performing his daily life. So I would like to again, this is my case. So I would like to again thank Harvard Global, Orthopaedic Sona Global, and NOFAS for providing me this opportunity. So the floor is open for any discussions if anyone would like.
Thanks, Dr. Subhash. Do you mind going back to your X-rays so that we can have those up for the discussion?
Yes, yes.
I don't see any hands up yet, but I have a question that I'm sure a couple other people have as well. And was there any discussion about doing an external fixator in the meantime, and then doing a CT scan, when kind of the timing of the CT scan relative to that?
Yes, of course, there was a discussion of putting him on external fixator, but in our part of the world, performing 2 surgeries, it's very difficult for our patient to convince them to provide 2 methods of fixation. So we largely follow single stage management, but we wait until the wrinkle sign appears, then only we proceed for the single stage fixation.
Thank you. It looks like Dr. Woolley has a question. Go ahead.
Yeah, that's a great case. Thank you for presenting. My question is, well, can you go back to the sequence of how you fixed it? Did you go to the fibula first, or how was your thought process into fixing it initially?
Yes, usually we fix the fibula first. In this case also we fix the fibula first. However, we fixed with the single anterolateral approach. We fix the fibula first and then fix the picture sequence is not appropriate in this slide, but we fix the fibula first, then fix the tibial pilon. Why we choose anterolateral approach is that because we want to directly visualize the joint, so we chose anterolateral approach in this case.
So I'm just curious to know if anybody else would do something different, or is it like standard to go first fix the fibula, check out, get out the link, and then kind of fix that pilon? So does anybody have any other thoughts on that specific treatment pattern or treatment sequence?
I think Dr. Daman has his hand up. Maybe Dr. Daman has a comment about that.
Yeah, Dr. Subhas, it's a nice case presentation. The only thing I want to know is how do you deal with central impaction? I think there's the impaction in the axial CT scan. Yeah. In axial CT scan, there's a central impaction. And I think the varus deformity is due to, maybe it due to uh, uh, not address that central impaction initially. Because in immediate pre-op also, do you have immediate pre-op X-ray, immediate post-op? Immediate post-op X-ray.
This is the immediate post-op.
Yeah. So if you look closely, maybe it's due to the view, but in immediate post-op and 6 weeks post-op, can you put that in both same place? Okay. If you see that in 6 week post-op, the medial and lateral joint space is not equal. That means there's a varus deformity at the 6 week of time. And if you look closely, in immediate post-op also you have some sort of talar tilt there. That means the impaction, that what I am feeling, that impaction is not corrected that's my opinion only. So, and do you have CT scan post-operatively?
No, we don't usually do CT scans post-operative.
Yeah, no, routinely I also won't do, but if you see in your 6 week post-op, when the patient is not in weight bearing right now, and if you see the varus deformity or anything going wrong there, I think CT scan is indicated to rule out, because patient is walking on that limb throughout the year. So that is the high risk of arthritic changes. I think patient has some problem right now while walking, or is comfortable.
He complains of only mild discomfort during defecation using the pan. In our part of the world, they don't use, most of them don't use the commode, and he has only have difficulties while climbing downstairs. Rest of the thing is having no issue.
Okay, so how do you deal with that central impaction in this case? There's the impaction, I think. When in axial CT scan, there's impaction. So how do you correct that?
So we retrospectively thought that we might needed to put some graft, primary bone grafting at that stage, but we didn't do in that time. We think that that is the one reason, or maybe some supplementary plates, small mini plates to hold the subchondral maybe loose fragment during reduction. That could be another reason for that collapse. But it's retrospective thinking. We didn't do during the primary fixation, so that's for the floor to decide, so that we will do it next time.
Yeah, so I think in tibial pilon fracture, I think the impaction is more important to address. I think this is the thing. And in the post-op X-ray, it's very difficult to say because there are lots of implant. So it's very difficult to say without CT scan that there is any problem with central impaction is corrected or not. So I think CT scan is highly indicated at the 6 weeks of time. And if there is varus deformity, you have to correct at that time, so the patient won't have problems. Thank you.
Thank you. I think Dr. Haller had his hand up next, and then we have a couple of questions from the chat after that as well.
Yeah, thanks. Justin Haller from University of Utah. I was just going to one comment on Dr. Woolley's question as opposed as asking about sequence. For me personally, I usually will fix the fibula first when there's complete articular injury, so C-type injury. This one's more of a B-type, so I think you could fix the fibula first or second, depending on how it was going to help with your reduction. I think here maybe the fibular plate kind of obscured any visualization of the reduction on a lateral view. So I may have chosen to fix the fibula after on this one. And I think back to Dr. Damon's point about the impaction here, I think it's really hard to fix this kind of anterior medial impaction with a anterior lateral approach. And I think, For this one, I probably would have done more of an anterior medial approach to really address that impaction on the shoulder. But I understand why you did an anterior lateral approach, and it looked like you did a really nice job with achieving reduction of both the plafond and the fibula. But I probably would have done two different approaches. I've done a real posterior lateral approach for the fibula, and then an anterior medial approach to really address that kind of shoulder impaction on the plafond.
Kieran, do you want to go ahead?
Yeah, I mean, I'm not really a Pilon expert here. I'm just applying the same principles I would apply for like a distal radius as an upper extremity guy. Is there a role for doing some sort of like spanning external fixator to offload the joint when you have a lot of joint impaction like this? I mean, I'm thinking like if you're piecing together the articular surface, you have this central impaction, tamping it down, using the talar dome as sort of your template, and then maybe using bone graft to fill in that void, and then perhaps putting an external fixator so you're offloading it. And it brings me to the question that was raised in the chat by Nicholas Okumu about potentially, waiting on weight bearing this patient rather than starting them at 6 weeks just because of that joint impaction. Curious what the faculty, Justin, maybe just because you were talking about it specifically, and K-Rod, could you comment on that perhaps? Like, would you ever do that in a case like this?
So just so I understand your question, X-fix in addition to internal fixation, is that right?
Yeah, spanning X-fix, perhaps waiting on weight bearing, like, if you have a lot of central impaction and you're worried about the joint surface being highly comminuted.
I've certainly done that. It's not a common practice for me. It's mainly used for what I deem unreliable patients, or patients who I think are going to weight bear earlier than what I recommend, or situations where the joint is really in a bad spot and I don't have individualized fixation into these impacted fragments, is when I'll kind of add the external fixator in addition to internal fixation. In terms of weight bearing, I rarely allow patients with a Pilon fracture to weight bear before 10 to 12 weeks, based that predominantly on whether it's B or C type and how many articular fragments there are and how much impaction there was. But usually I wait a lot longer for weight bearing, just because I worry about early collapse, particularly anterior kind of migration of tail is kind of like what happened here, and incomplete healing. So yeah, I would have waited for this one, but I don't know that we've totally figured out when to initiate weight bearing after a Pilon fracture.
Thank you. K-Rod, I think you were next.
Hi, good morning, everyone. Always so nice to be at these meetings. So a couple of just comments. So going back to fibula first or not first, I don't have a preference one way or the other, unless I fix the fibula first, frankly, only when it's gonna be of value, either because the fractures are a little high or the fracture pattern is simple, and you can actually fix it well and anatomically to actually provide a good indexing for length and rotation. Because if the fibula is kind of as blown out as the tibia is, just spanning it isn't going to help you if you're not providing the appropriate length and rotation to be useful. And in fact, it may be detrimental to your repair. You may find yourself having to undo it after you fix the tibia to kind of adjust it to what it should have been initially. So there's a little bit of that decision making. In terms of how to deal with a very comminuted plafond, it's hard. And even when you identify the impaction and you disimpact and you properly grafted underneath, the problem often with these little, very, at times, just the cartilage and a few millimeters of bone is that they may look fine in the x-ray initially, and they might look like you replaced them in the anatomic position, but they'll die off. They'll necrose because they're just little pieces of bone separated from the rest of your bone by a ton of dead bone graft, right? So it's no guarantee that a super detailed anatomic reconstruction of the joint is going to persist. And that's why, frankly, many of these things develop significant post-traumatic arthritis, and often have to end up in fusion and so forth. But it's worth trying. It's worth reducing any marginal impaction or any and grafting it just to support it. But it's tough to keep it there after a while. And I agree with Dr. Haller. I don't weight bear these people before 12 weeks. My progression is touchdown weight bearing for the first 8 weeks, 50% from week 8 to week 12, and then weight bearing as tolerated after week 12. And in regard to the other question about do I ever transition with an X-Fix? Oh yes, when it's highly comminuted and I have modest confidence that the joint reconstruction is going to hold, I will occasionally keep the X-Fix for the first 4 weeks.
Carol, just to add on to that point that you just made, actually, just for everybody's awareness, in our full curriculum, there's a Pilon fracture that you fix. The whole video is available for free thanks to our colleagues from JOMI. And in that case, I think you do use an external fixator, not only to help you get the reduction intraoperatively, but you leave it on post-op, I think, to augment the fixation. So
yeah, I freely admit I end up taking the coward's path and doing that more often than I should, perhaps.
I think I mean, at least from an upper extremity guy's perspective, I think it's a useful tool.
No, I agree.
Dr. Appleton, do you want to go? And then there are just a couple more questions in the chat that we'll circle to.
Thanks, Kelly. Just a quick comment on Kieran and the X-Fix. I leave them on very frequently, just for the wound, especially. So if I'm concerned about a wound at all, and there's something like this, I would X-Fix it first, then fix it. And I leave the X-Fix on for 2 to 4 weeks just to make sure the wound heals. I found it very helpful for incisions to leave an X-Fix on. That's all.
Thank you. From the chat, we have one question about using a distractor during the surgery. And then another question we touched on briefly, considering bone grafting for that central impaction, but just a question about whether you're using autologous bone graft, autograft, allograft, if anyone wants to comment on that.
Subhash, do you have allograft available in your hospital?
No, we don't have allograft. We only use iliac crest bone graft, and unfortunately, we don't have the distractors as well. So for us, it's either calcaneal pin traction or direct visualization of the joint. So that's our limitation.
We in Nepal, we don't have a bone bank as such, so I think it is one of the big problems. Even for all the surgeons here in Nepal.
Yeah.
And I'm happy to offer my anecdotal experience with some of the artificial fillers. I've been very disappointed with the calcium phosphate fillers near the joint. I think they're not as sturdy as bone graft, whether it's iliac crest or allograft. It doesn't get absorbed nearly as well as the providers suggest it does. And in the events where the underlying, let's say, joint is damaged and there's exposure of the synovium to the filler, it's over. It becomes that debris becomes very inflammatory. So I've stopped using the calcium phosphate family of fillers for the plafond. But that's just my anecdotal experience. I don't know if there's any evidence to support that or not.
Thanks, Kieran. Just to be the annoying timekeeper here, I want to remind everybody that we are running out of time for this presentation because we have a few more excellent ones to come. So just last comments from the faculty, and then we'll move on to the next presentation if you guys don't mind.
Yeah, just one more comment was to use about the use of the distractor. If you don't have a distractor, the X6 is perfectly useful for a distractor, right? And so you could transcalculate a pin, and you can actually work your way on both sides if you want to have to double incision. So the X6 can be a distracting tool per op while you're doing the surgery and while you're kind of fixing that and getting your framework going.
And there's one question that I think we would be remiss to not talk about is the post-op rehab protocol. A few of the people in the chat have asked about this. Subhash, you said that you first had the patient non-weight bearing for 6 weeks, and then they started weight bearing after that. Is that correct? What is your typical post-operative rehab?
Non-weight bearing for 6 weeks, and then gradual weight bearing as tolerated. I start from toe touch and partial weight bearing and full weight bearing. It's like my patients usually starts weight bearing at 3 month time without any aid. So that 6 weeks to 3 month is the period where they understand it's a progressive weight bearing exercise.
Great. And I think, Justin, you'd mentioned that you sometimes keep your patients non-weight bearing for up to 12 weeks. Is that right?
That's right. Routinely 10 to 12 weeks, unless it's, a Pilon light type thing where it's anterior plafond or supination adduction ankle with some impaction. I'll start those people like weight bearing at 6 weeks. But when it's a real Pilon fracture like this one, it would be more 10 to 12 weeks. But starting early range of motion after sutures were removed at 2 to 3 weeks, because invariably these people are going to get a relatively stiff ankle, and so really try to encourage as much range of motion as possible early on, but delaying their weight bearing for 10 to 12 weeks.
All right, thank you, everyone. That was a great case to start off. Great discussion. Why don't we move on to the next one, just for the sake of time?
Dr. Paul, do you want to pull up your slides next?
Yeah, sure. Can you see my slide?
Yes.
Yeah, thank you. Hi, I'm Dr. Sarthak Nepal. I'm an orthopedic surgeon at Nepal Orthopaedic Hospital. We are a non-profit hospital, 100-bedded, in the capital city of Nepal, that is Kathmandu. So let me present to you my case. It's a 49 years old male who had no underlying comorbidities, who sustained road traffic accident. That is, his bike was hit by a motor vehicle, that is a car, 45 minutes prior to arrival at our hospital. After that, he sustained pain over his ankle area. On clinical evaluation following the ATLS protocol, the primary and secondary survey showed no immediate life-threatening injuries and his vitals were stable. On evaluation of the affected part, that is the left ankle area, there was a wound of about 1 by 2 centimeters in the left medial calcaneal area. There was no active bleeding, but there was a gross tenderness and swelling with a limited range of motion, but his distal neurovascular status was intact. So coming after the stabilizing the patient, we sent for the imaging. In this patient, we sent for the ankle series, where we sent for the ankle AP, lateral, and the mortise views. The x-rays showed that there is a comminuted fracture at the left distal tibia with intra-articular extension, and there was associated distal fibula fracture as well. And hence, he was diagnosed as a case of closed comminuted intra-articular fracture of the left ankle, that is the tibial pilon fracture. If we could classify this fracture, we classified him as the Rudy and Elgore type 3 and AOOTA 4-3 and C3. After imaging, initial management was planned. I tried to keep the patient in the NPOs and give the antibiotic as well as the tetanus prophylaxis, and we temporarily maintained for the reduction. And the operative treatment I planned was in 2 stages. The first stage was the application of the temporary external fixation, and second, the definitive surgery after the soft tissue or the skin condition improves. So the main goal of the treatment for me was to maintain the fibular length and achieve the stability, as well as to restore the tibial articular surface and later buttressing the tibial distal tibia. At first, I took the patient to the operating room for irrigation and debridement and application of the external fixation. This is the image after the application of the external fixation. And we can see the proper maintaining of the length, alignment, and rotation after application of the external fixation. So after application of the external fixation, we did a CT scan in the patient. to identify if there was involvement of any other of a major fragment planes, as well as the articular impaction or the degree, and to look at the degree of comminution. This is the CT scan image. The first one is the axial CT scans. As we can see, the involvement of the anterolateral, that is Chaput's fragment, and the posterolateral fragment, that is the Faulkner's fragment here. This is the sagittal image. We can see the gross articular impaction, and this is the coronal image. This is a 3D image of the same patient. So after waiting for a period of about 10 days, I planned for the definitive treatment. I placed the patient in the lateral position, did firstly use the posterolateral approach between the peroneus longus and the FHL to fix the fibula and the posterior malleolus by using the open reduction and internal fixation. I fixed the posterior malleus by using a T-plate and the fibula by using a 3.5 mm DCP. In the intra-op, there was a butterfly fragment in the fibula, which I did a wiring as well, and then turned the patient into the supine position, and then incision was given for the anterolateral approach and fixed by using ORIF with LCP. And then after I did a MIPO technique for the medial aspect and fixed with the locking compression plating. This is the immediate post-op X-rays where we can see the fixation. We see the fixation in all the 3 X-rays. This is a 3-week post-op. I generally ask the patient to have to place the patient in a neutral dorsiflexion by using a slap for about 2 weeks. And after the removal of the suture in 2 weeks, I start the ankle range of motion. In about 10 weeks period, I gradually weight bear. I tell the patient to gradually weight bear. This is a 3-week post-op. But since the patient had severe pain, there's a slab still on place, but generally I do not recommend the slab placement for more than 2 weeks period. And this is a 3-month post-op of the same patient. Thank you. Any questions?
Thanks, Doctor. Can you pull up your X-rays again so that we can have those up for the conversation?
Thank you so much for presenting such a great case. If you go to your slides where you have X-rays with the fracture in the external fixator, I think that's a great spot to start the discussion here. Either Dr. Nepal or any of the faculty on the call, do you want to comment on what your goals are for a temporizing external fixator or for a Pilon? Dr. Hunch and then Dr. Rodriguez.
Dunford, you're muted.
Hello from Tübingen in Germany. Only one comment. For the X-fix, you should more traction on it. And it is better to do it bilateral in the calcaneus, then you can avoid this varus. And for the whole treatment, you have 2 less destruction of the primary reduction as well as of the secondary final fixation. So we have to take care of the external fixation like we take care of the internal fixation. The external fixation has a lot of good ideas to do it more balanced. Therefore, I recommend in these cases Steinmann pin in the calcaneus and do a bilateral traction, that you can also make the traction to the medial side. From unilateral, it is very, very difficult when you use 5 mm screws. They bend, or in this case, you see it, you stay in a varus. And this is also not good for the soft tissues. And another recommendation for as well for the first discussion, the pins in the tibia should be as proximal as possible, that you do not disappear or with later final osteosynthesis. Also mid and proximal tibia, and in the calcaneus make a bilateral traction. Kiran, I can send a special imagination to show this for the audience later on, not now in this session, but I can deposit in the chat for you.
That would be great, Dankert. Thank you. Sartak, my question for you on that point from Dankert is, do you have Steinmann pins that you could have done transcalcaneal, or is that just difficult for you to get?
No, we do have Steinmann pins, but mostly we that's according to the surgeon. You know, whatever we do, like sometimes we use a calcaneal pin traction, and sometimes we do external fixating. That if the patient is very poor and is not able to use the external fixation, and we definitely choose the Steinmann pin traction for some time, and then come for the definitive surgery, I think.
Well, I was suggesting using the Steinmann pin in the calcaneus as part of your external fixator construct.
Yes.
Not doing it as traction. Dr. Daman, I think do you have something to say?
Yeah, Dr. Sartak, the nice case, well managed. Just a comment, just like Dr. Kiran and others are saying that we use delta frame like a Steinmann pin in the calcaneus that will help you intraoperatively also, because we won't have
delta frame.
scatter. Yeah, and other thing is the main role of external fixator is to reduce the fracture as much as possible. And if you see here, there is still there is some bias deformity. So if you are not getting well-reduced fracture with the external fixator, you can go for fixing fibula, because the wound is not there, wound is in the calcaneus side. So you can fix fibula while doing the external fixator. That is just a comment.
Yeah, I completely agree, but there was a gross swelling of the ankle, so I didn't want to touch the angry part, so that is the only reason I initially did not do the fibula. But I completely agree. We can fix the fibula at the time of external fixation.
Thank you. Kara, did you have a comment?
Yes, I was just going to point out the items that were already mentioned. Essentially, a transfixing calcaneus pin, so a pin that goes right across the calcaneus, gives you a bit more balanced ability to apply traction. But if you only have non-transfixing pins, this would be as I was proposing for the other case, because this is a simple fibular fracture. This is a fracture you could fix early because it gives you indexing and length, and that will be useful for your second stage. And then you can use your unilateral frame medially and not laterally to kind of just switch the size by fixing the fibula if you only have a unilateral frame opportunity.
That's a really good point. Dr. Haller, you had your hand up next.
Yeah, agree with what everybody said about, transcalcaneal and all that kind of stuff. And I agree with Dr. Rodriguez. Usually I would fix the fibula early on in something like this. However, my hesitation with fixing the fibula is, for this case in particular, is you can kind of see that posterior fragment, how displaced and rotated it is. That it, in looking at that, I would sort of plan for a posterior approach like you did. And so in that scenario, I think combining like a posterior lateral approach to address both of those things makes sense. And so for this one, in particular, I might hold off on fixing the fibula. But just to point out, like's been said, I will over distract these when placing an external fixator and at that initial surgery, just because you know that when you're coming back, and I think you said you came back in 10 days or something like that to fix this, it's going to be really hard to really adjust that posterior fragment. You did a nice job, but I think over distracting, you can kind of see here your length isn't quite right. It's just so much harder at 10 days to kind of adjust those things. And so I'll kind of get the length of the distractor and then over distract, so you see some really good distance between your plafond and your talus. I think that could have helped you here when you went back at 10 days.
Thank you. I think intramedullary fixation of the fibula has come up a couple of times in the chat now. Is the advice still, if you can't get the fibula perfect, don't fix it right away? And can you get that with intramedullary fixation? Maybe Dr. Woolley can take that first.
Yeah, you can definitely take it with I've done just a rush pin just up because that's pretty high up. And agreed, if you're using an external fixator, you're using like a delta frame or any type of like what was discussed before, you can actually have that fibula out to link if you over distract, as Dr. Heller said. One other comment is if you're doing an external fixator as a distraction initially, I don't know when that factor initially came into your institution, and so that timing is important because sometimes what I do the distraction and over distract just to keep it out to link. Sometimes just by moving a little bit or just pushing I can get that posterior fragment a little bit better and the X-ray, which also helps with swelling, compression, and all that stuff, and kind of helps your fixation afterwards. Obviously, if it comes out after 10 days, and most of the settings that are in this chat, it won't be able to move as much. But if it gets initially and you're doing that distraction, sometimes just kind of manipulation of that gets you in a better position to ultimately fix it secondary. So yeah.
Thank you. Dr. Shah, do you have a comment?
Yes, thank you. It's a very difficult fracture and it's kind of nicely done. As everyone said, that my problem with the X-Fix was the reason for putting on an X-Fix is to have your length and alignment in the intermediate period before you go for different surgery. And as we can see in this case, it is still a bit varus and still a bit not adequately distracted. So that's one point. And then the question arises that would the same would have been the same position, and then if he was just given a back slab or splint in the first place instead of doing X fix. Secondly, about fixing the fibula, in the core curriculum, there are a few lectures in which they say that if you are going for a stage treatment and if a fibula is simple, then you can go and fix it and for your length to attain your length and alignment. But in case if you have a posterior mal, and as Justin Holler mentioned, that if you do plan to go posterolateral, so instead of fixing fibula first and going back again posterolaterally, so you can just wait and do both fibula and the posterior mal at the same time. So that was pretty well done in this case. My question is that there was a lot of impaction. How was that addressed? And considering there's so much metaphyseal comminution, was primary bone grafting would have helped here or not?
I agree. There was a lot of central impaction in the case, so I had bit of a dilemma of whether to do a primary bone grafting or not. But we were, I was able to put the fragments together and just fix it, and the alignment looked good, the articular margins look good. So I did not do a primary grafting. So I think there's a lot of dilemma in the case whether we should do a primary grafting in such a case or not. I think it's a discussion that I think should come up. We can discuss it furthermore.
Thank you.
It
I see
depends
that
on
Dr.
surgeon.
Shears joined as well. Do you have any comments on the case? And maybe you can talk about options for bone grafting in cases like this, and what you prefer when you don't have bone substitutes or allograft especially.
Sure. So I guess before bone grafting, just commenting on the fibula fixation, I do think if you're going to fix the fibula, it has to be anatomic, as has been said. So I don't think an intramedullary pin is probably adequate. So if you're going to start with fibula fixation, I would recommend, plate and screws, an anatomic reduction. for all, as has been said in this case, I might have been hesitant, just like Dr. Haller said, because this is likely to need a posterior approach to the tibia. For bone grafting, I've kind of gone away from, for most like small articular impactions, I've kind of gone away from even bothering with bone grafting. I think the metastasis, that area tends to heal pretty reliably if you get adequate fixation. And I haven't found that, you know, putting a small amount of allograft is really worth it. I don't think most people have bone banks anyway, so I wouldn't worry about it. If you have a larger metaphyseal or larger impaction and that you really feel like needs to be backfilled, I find that proximal tibia autograft is a really nice alternative for easy autograft in a large volume without the kind of hassle of crest. So it's a nice alternative that everyone hopefully has access to, even without a bone bank.
Thanks, Dr. Shear. K-Rod, you had another comment.
K-Rod, you're muted.
So apologies. I know we're talking about fixation of distal tibia fractures, and we want to present the different approaches and thoughts and organized protocols we have in our heads to kind of get this done safely. You know, when I see this, I also think of primary fusion. So I wanted to just drop it out there for the faculty. It's like, what is your criteria for a potential primary fusion? This is I believe, if I recall, this is a 50-year-old patient,
49 years.
worker, right? And perhaps I don't know what his resources are. If there's a problem or an infection, I don't know if he would be able to afford subsequent surgeries or not. So when and in what setting is that even a consideration as a primary approach?
I would do a primary fusion in a case where the patient is slightly older than this, who is who is not really working, and who is slightly older age and who does not need to have who does not need to have an ankle range of motion as such. And that is the only thing I would lastly suggest to have primary fusion. Otherwise, there'll be a lot of problem with the ankle motion, I feel, especially in a young patient who are in a productive age group and who are earning. So I think that'll be a big problem for them.
Well, I agree, but I would argue there will be motion problems even in a good result. So a lot of these folks refuse because of concern for pain, and we see sometimes the fusion as a faster or more assured way back to labor than a almost successful or partially successful repair. So I'm just curious.
Thank you, Dr. Rob.
I don't have an answer to that. That's why I'm asking the folks here.
I think
hopefully going to get into that a little bit more. Sorry,
I think if we counsel a patient in the first setting regarding the you'll not be having much of ankle motion, the patient will certainly disagree for the primary fusion, I feel. So I've never done that primary fusion in a younger patient, just done it in an older one. So I think, yeah.
Luckily, we have some great cases on exactly that topic coming up very soon. And, really appreciate all the comments, but we do need to move forward with the next case. So just a last few comments, if there are some, and then we'll move on.
Maybe Dr. Radwan and Dr. Shear, while the next case slides are being pulled up, you want to give your last comment.
So a couple of things here. I also believe that maybe if the X-fix was on the medial side, would be better, even though it's more annoying to put pins in the calcaneum from the medial side. But when I look at the base of the medial mal, you do have a shortening there, and this is in slight varus position. So, like people already said here, giving some distraction with the X-fix. If the X-fix was on the medial side, I think we would have a better correction. Initially, it would make the surgery easier. And like this is, so if we do this as open approaches, like posterolateral and then anterolateral and then medial approaches, if you have any skin problems here, this is a nightmare to treat later, right? So if, for example, you're talking about a setting where we don't have a lot of options for hardware, probably the options for skin grafts and reconstructions and that type of stuff is going to be also limited. So I believe that a long anterior approach here and a primary fusion with a plate would also be a great option. Just got to remember that ankles that are fused, they clinically do like very, very well. And even though we had a great final x-rays with the plates and the reduction in the end of this case discussion here, we are just, this is gonna, the arthritis is gonna come. We just don't know whether that's gonna happen in a year, in 2, or in 4 or 5. But this patient will very, very likely have bad arthritis in the ankle, and then we will have to deal with a lot of hardware in around the ankle, a lot of incisions to plan a fusion in the future. So I think that the results here are great so far, but I do agree with K-Rod that the primary fusion is a good indication here, I believe.
Thank you.
Thanks, Fernando. For the sake of time, let's move on to the next case presentation. Sorry, Sarthak, to cut this excellent discussion short. Fantastic.
No problem. Thank
Really,
you.
really
Thank you so
excellent.
much.
Yeah, really great.
Thank you so much.
So I'll invite Fabio to pull up his slides next, if you don't mind, Fabio. And Sarthak, if you can stop sharing yours. Thanks.
Hi, thanks all. Thanks for the invitation. Hope you're seeing my presentation mode.
Just it's pulling up now.
Yeah. So thanks again for the invitation. Any problem?
Fabio, we don't have it in presentation mode. It's still just in slides mode.
Okay, I will change this. Just 1 second, please. What about now?
Yeah, perfect. Thank you, Fabio.
So thanks again for the invitation. Let's see some old friends here. And I'm from Brazil, just to know and then to mention where we are. I work in ABC Hospital. That is a region in São Paulo. Here's a little map from Brazil. And in southeast, there is São Paulo with the population. And the hospital that I work holds like the tertiary hospital in 2.7 million people in this area. So the case that I want to present you, it's a 37 years old that fell working at 5 meters and presenting with this open lesion with posterior medial scar. And also we have this initial X-ray we can see the fibula fracture and also a lot of comminution of the joint. I want to point some my views, what was discussed in my presentation. The first thing that we did in this case were cleaning in the operating room and put an external fixator. As Dr. Fernando said, we prefer the medial one. We a lot of times I don't prefer to use any pin and stymon pins because they don't have the treat in the middle, and sometimes it can shift for medial or lateral. So when I do have some of them available, I would use it. And the second thing was discussed was about the fibula fixation. And when you see this one, that is a simple proximal tibia. The problem when you're thinking your ending or your less stabilization, you think maybe an approach in an appropriate locale will not help for you. So that's why I don't prefer to use it. Only use a nail in a simple one. I think that's is good because you don't have any little small approach. But in this case, we put this external fixator and waiting just a little bit for the consolidation, for see how the soft tissue will work. And then we made the CT scan to plan the fixation, and here you see an axial view, and here a sagittal one. You can see that as the first case, all this is a thing that we always see is all this articular comminution. In this patient that is a smoker, we really in an open fracture we really have a concern about the infection and soft tissue problem. That's why we realize external fixator with a ring external fixator treatment. This example, this is a proximal tibia and another case, but just to show how the principle that we use like the arthrodiastase with ligament ataxy, and we fix the distal and proximal with the other bone, and then do a lot of distraction. What we see a lot of times, and that's a thing, really important thing, this distraction a lot of times don't do a really good articular reduction. That's at this time we need to reduction the articular surface. And for fixing the articular, you can put it at the last when you already reduce it. You can put some screws, or we really like the olivet wires for hold the joint. So that's the case, the frame that you mounted. We first put the first proximal 2 rings, and then mount the distal ring, distraction, reduce the joint, and then fix a lot of external fixator. As are discussed before, we prefer to leave the calcaneus distraction to protect all this reduction for some weeks, around 8 weeks. At this time, after 8 weeks of holding it on position, we take off the frame of the foot and start the therapy for moving the ankle. That's the X-ray of this time. And at this time, we should probably put some autograph here, and that's already discussed. And I really think it's important to put something in this case, is all, because we have a lot of comminution and almost no bone. I think the problem, we have some problem about the infection, but also I think it works like a scaffold to prevent collapses that you will see in the next slide. So this patient was able, after 4 months, to weight bearing, and this X-fix stays until 6 months. And this is an image 3 months after taking off with 9 months of the accident. When we see a little virus collection, maybe because that is meshed bone, but with some kind of bone healing and bone consolidation, it is a near post-op of this case with a little varus, but we have a good, nice articular correction. And the good thing is we had like this soft tissue. This is the initial lesion. You can see the pins, and you can see how all this all have good healing of soft tissue in this really good on a so comminuted fracture. Also, as already said, we think have a lot of chance to have some arthritis. And as arthritis, I'm not sure, but probably comes from the original trauma. The trauma that could do so comminuted fracture will lead this patient to have some arthritis. And we're using an external fixator protect not to have it. Just 2 articles, this what do we have? That's why I think this discussion is very good, because we are talking about really not so frequent lesions. And about the publication, okay, we have a systematic review from 2020 with only 3 articles could be included. So we have only cases groups doing, and you see like this, a lot of them, because we have few people don't have a lot of difference. For sure, the X-fix will always show some superficial infection, that anyone that treated with an external fixator knows that we have a lot of superficial infection that a lot of times makes no difference. And for internal fixation, a little bit more infection, deep infection. And this is the publication of 2021 that shows exactly as the case that I showed for you, with few deep infection, 8%, I think is 53 cases, and 80% of consolidation, but the X-fix avoid the severe soft tissue complication and residual some in alignment. So showing for you this external fixators treatment, I think we choose for treating is a tool. You must know to use the plates and also the external fixator. I think is a really useful tool, and we choose them for the patient who have very important soft tissue injury, better for more simple fracture in the joint, and for the host C. And I really, I think it's important to see which patients with that ankle belongs to who. The patient that is smoker, diabetics, problem the problem will show better, so we prefer percutaneous treatment. That's why. Thanks for the invitation.
Thank you, Fabio. We wanted to include this case because it shows a completely different way of approaching these highly complex fractures. So thank you for that. If you could go back to your slides of the X-rays, that would be helpful.
All right, we can start out. It looks like Dr. Hunch has a comment. Go ahead.
Yes, my recommendation is to use the time when the X-fix is on site, ring or delta frame, to control it and to make a secondary reduction of a malalignment of the axis, like in this case. In the time when the fracture is not healed yet, you can make simple, without anesthesia, reduction of the varus, which was in the end of the healing. Please use this time when the fracture can be modified a little bit in the axis.
Thank you. Dr. Haller, go ahead.
Yeah, just a couple comments. I think it's you did a really nice job of getting this patient through his injury, not having an infection. That was a great outcome. I think for this one, maybe fixing the fibula could have helped your overall coronal plane alignment, because it's really probably hard to control with that fracture is really short segment. And so it's probably really hard to control with a frame, and fixing the fibula probably would have been outside the zone of where it was open, and could have done that with a plate and screws. It's a pretty simple injury, but overall looked really nice to get this to really fill in. I did want to comment, it keeps coming up about arthritis from the injury. I just wanted to put a plug in for a study I did on pigs, where we did a tibial, like a Pilon fracture model in pigs. And it's true that 40% of the articular chondrocytes die from the injury. That's both on the talus side and the plafond side. So we do face an uphill battle with reconstructing a joint and allowing the chondrocytes to more chondrocytes to come into play. So it's that's not to say that I go to fusion very often or at all. Usually I still fix them and allow the body to heal the injury, but we do face an uphill battle with these really severe plafond injuries. Hopefully that article will be published in Foot and Ankle International at some point.
Thank you for the comment. And what would be do different in this case, for sure, two things. I think this one is a fibula that would help for fixing it because it's a simple one, and put some graft at the end. I think would be before the collapse. I think would help also. But thanks for all the comments.
Thank you. Dr. Shahab, and then we'll go to Dr. Shearer after that.
Thank you for the case. It's a pretty bad injury, and when you put in your temporizing external fixator, it looked pretty good. You corrected the length and alignment in this case. My comment is again about the fibula. This is as the fibula fracture is out of zone of injury, fixing it would have helped in getting better alignment at the end. Also, if you won't want to do putting on a plate, this can be a good case for intramedullary nail, which is coming in the chart regularly. So better alignment of the fibula would have helped avoid the varus in the end. But overall, it was an excellent case, especially with the first external fixator, and then managing it with the ring external fixator. Sorry, I missed it, but what was the interval between the first frame and the circular external fixator? After how many days did you convert it into Elizarov, and wasn't any pin holiday in between?
We changed from the Delta frame for the Elizarov in 10 days. and then stay with the resolve with the ring in the calcaneus for around with 2 months.
Thanks, great case. I was just going to comment that I think I see a lot of these cases like sent from around the world, and a lot of people probably would have looked at this Delta frame and said, oh, I'm just going to manage it in this Delta frame, and that might work. And just wanted to kind of point out that these conventional frames typically only last about at best maybe 6 or 8 weeks before they start to get loose and fail, and then you reliably, and by that time the metaphysis, it's just not enough time for it to heal, and it will very reliably collapse into varus. So I like what you did, because a circular fixator kind of hopefully gets you around that problem because it lasts so much longer. I think the challenge is that even in this case, the 2.5 months wasn't maybe enough to get it all the way to the finish line and avoid the collapse into varus. And so maybe you could comment a little bit on how you decide when to remove the frame, because a ring fixator, I mean, you could keep on for 6 months. So yeah, I mean, you can keep it on for a really long time. I wonder what your protocol is for sort of how you decide. That's one of the hardest things, I think, is deciding when do you remove the ring fixator? Do you dynamize it? Kind of what's your protocol for frame removal?
Right. And what you usually do is to hold with this frame not much a long time. If you leave it a long time, I think we need some range of motion. So if we could not give some range of motion, it will be fused. So we wait like 2 months with this ring. This is not as so stable, is much more than a lateral, monolateral, but the circular frame is much more stable. But we can only put some key wires and tension it with some tension in distal frame. Usually it used to heals in like 6 months. I think this is a good time. The thing is, at the time we have 2 things to do better also. If you have like a carbon ring here, what much easier to see if there's bone heal. So we can try to see the consolidation and X-ray, but it's really hard. And about the dynamization, I think it's not to simulate the consolidation. At the end, we get loose the threaded rods, like to see if it's some kind of consolidation, but it's difficult to know it. So what we do or advise to do better, it become easier, and to use this distal ring by carbon, they can see better the X-ray. But I agree with you, it's really difficult to know where is the real time to take the X-fix out.
Yeah, I think, I think dynamizing, like getting the motion going by removing the foot plate makes a lot of sense. And then you can, compress through the frame a little bit too, because it does look like the metaphysis is slow healing, and that may actually help. Although everyone's commented on fibula fixation, I love fibula fixation. I think in this case, actually, it might have made it hard to compress through the frame. So if you are going to treat it with a ring fixator, I might have been hesitant about fibular fixation so that you could get more compression of that, especially with how comminuted the metaphysis is. And then it's always nice if you can to just loosen those nuts a little bit and dynamize the frame so that before, and let them weight bear a little bit before you start, taking the frame off, because it's a lot easier to keep them in the frame a little longer than it is to have to like reapply the frame afterward. And then also, if you're in doubt, keeping them casted after you remove as well is another option to try to prevent collapse. But yeah, these are a hard case, but it's great work.
We have one quick question from the chat about using a 4-foot pin to prevent equinus. And then maybe you could address that, and then we'll go to Dr. Radwan, who has his hand up.
I think this foot ring prevents the equinus. Sometimes I put this ring through the forefoot. I think we have a little bit more cavus than equinus. But we have more hardware, so sometimes I don't put it, but I think it would work, and you can use the whole frame till the forefoot. I think it works also, and prevents better the equinus for sure.
Thank you. Dr. Radwan?
Thank you. Well, Fabio, great seeing you, man. Unbelievably. We used to work together in the same clinic in Brazil like 50 years ago or so, but it was great seeing you, man. And I think that just echoing like Dr. Shar's thoughts about the pin loosening. So the kind of bad thing about doing a great job on your first delta frame, if you go back to the delta frame images, the AP view is great. So you see that you have almost like 90 degrees between the tibia and yeah, this one here. So you look at this, it's almost like this is great and this is great too. So almost like this encourages you to transition from the delta frame to the circular frame because you have a great job here, right? Maybe not perfect here, but on the AP view is great. But because of the stability of this frame here, for sure, in 4 to 6 weeks, all the pins will be loose. So don't think that this is going to be a permanent solution because it will not. And then if you don't transition this guy to the frame, to the circular frame, this will all get loosened up and will fail. And I believe that in this case, especially also because it was an open fracture, having the final solution with another frame, the circular frame, I think was great. I think that's a very nice case.
Thank you. One more question from the chat about if doing a primary fusion, what construct do you use? Nail, plate, screws, mixed, I think. This was addressed a little bit in the last case, but for this case, does anyone have any comments in particular?
Sorry, it was about doing the fusion at this time.
Yes, then if you decided to do a fusion, what would you use for the fusion?
No, for a fusion, I use probably internal fixation. I think also depends. I think that's the thing. We have a lot of tools. We have to manage all these tools. And I think the external fixator is really good for when we have bad wounds and when we have infection or a not good patient. And we a lot of times have a patient that will not help us. Exactly the opposite. So I think this prevent really bad complication with soft tissue lesion, mainly the soft tissue problem. I think the patient will stay a lot of times in the hospital, a lot of surgeries, and here we have like 2 surgeries, 3 surgeries is the really short treatment and all percutaneous treatment. I don't prefer, and I never did a primary fusion in a fracture, but I think we can give the chance for healing and give the chance for see how the patient will hold and feel with the ankle. And we have time to do the fusion later, and probably and it's good for the patient also know that he tried and tried to fix and try to make it works and have the option, okay, it doesn't work, as said the publication, all the damage in the injury. So that's the case that probably, okay, he had his time to try to heal and try to use the ankle and ask for the fusion. So I ask for the fusion. I usually only use the X-Fix for fusion when I have a lot of deformity, and also when after the deformity, when we have infection. And I think that will help in this. We have different, I talked something, Dr. Hadua also said, and very nice to see here again, but said about some alignment is really more difficult with, this is the reserve, really classic reserve, but we have some hexapod system. We can correct all this alignment for lateral medial much easier. So this would be another tool that would help in this case.
Perfect, thank you. We are running a little short on time. So that was another fantastic case, great discussion. But let's go ahead and maybe move on to the 4th case.
Well, since the next case is actually Fosse's and he had his hand up. Fosse, you can make your comment while I get your slides up and ready.
Yeah, so just a quick comment about the conus deformity with the frame. Not everyone has access to a foot plate. So one way of doing it, and if you are not afraid of putting in a pin in the metatarsal for various reasons. One trick is to put a sling or a TheraBand or a rope and tie it with the frame on the side and it can help you put your foot in and can prevent the equinus deformity.
Great comment, Fassi. Thank you. And so all these conversations are phenomenal. I hate to cut it off, but let's move on to our last two
Yeah.
cases. So
Can
Fassi,
you go to the first? Can you go to the first slide, please?
Yep. Sorry about that. There you are. Go ahead.
Yeah. Next slide, please. So the learning objectives for this case are to talk about the stage approach for open Pilon fractures and also discuss a salvage option for these fractures. Next slide. So this was a case of a 50-year-old male who was a truck driver. For some reasons, he was trying to do something with the tires of the truck, and the emergency brake failed, and then one of the tires went over his leg. When the first place that he went to, he was advised amputation, but they did pin a tibial traction pin. Next slide, please. Then he was operated, and then an external fixator was put in, and the necrotic area was removed, and partial thickness skin grafting was done. Looking at this external fixator, as you can see, there is a Steinman pin across the tibial, the calcaneum. There's a rush nail in the fibula, which is trying to make it aligned. And there was a very comminuted median malleolar fracture. And there's one pin that is going through the malleolus to try to fix that as well. Next slide, please. So this frame was on for about 2.5 months, and then it was removed because of some pin site infections. So he was on pin holiday. He was given IV antibiotics as well as oral antibiotics. He was planned to be repeated for revision surgery after 2 weeks, but as is very common in our parts of the world, you tell the patient to come back after 2 weeks and he'll show up after 2 months. Next slide. So the question here is, how do we go about it? Because can you go one slide back, please? Yeah. So as you can see, the distal fracture, the distal articular fragment is very small, and considering that it's already compromised skin with skin grafted, so and previously slightly infected as well, so it's kind of high chance of the fixation may not work that well. Also, there's a lot of osteopenia, and access to locking plates is not that common. So another option that we have is to go for a fusion. Next slide, please. So this was a fusion that was done with a sign nail, and bone grafting was done for the fracture site. Next slide. And as you can see, there's subsequent follow-ups at 15 weeks, and he had a good motion. He's walking, and then the next follow-up is after. Next, please. Is at almost a year, and as you can see, the skin has pretty much healed, as well as the fracture site is also kind of united. Next. And this is his follow-up at about a year and a half, and his last follow-up was at around 3 years. Next slide, please. So as you can see here, the fracture has pretty much healed. He's fully weight bearing. He's back to his job as a truck driver. The problem with these cases is that you're trying to fix or do the ankle fusion, but invariably you also do the subtalar fusion as well. So there is a problem with the foot function at the end. But considering how bad the fractures are, especially the Pilon fractures, the patient has a plantigrade foot and he's fully weight bearing, so it's kind of a win situation in and out. Thank you, and we can go on to the discussion now.
Thanks, Fassi. Great presentation.
Yeah.
Since Dave Shearer, are you still on the line? Would you like to make a comment on this case?
Sure. Yeah, I think it's a challenging problem coming to you. It sounds like a couple months after some initial treatment with a really terrible soft tissue envelope. I think the soft tissue is really what's going to drive your options for treatment in this case more than the bone. You know, when you go maybe one click forward on the slides, I think where you were making your decision about what to do, I think maybe to another click forward. You know, one option would have been honestly to just treat this in a cast. I think they might have been able to go on to heal this. You know, the joint doesn't look terrible. There's definitely some varus there, but it's not, you know, might have resulted in an acceptable outcome. So I think that would have been an option. I think internal fixation with plates and screws, I think would have been challenging at this, you know, this far out. The joint's usually mostly healed at this point, so you're just treating the metaphysis primarily, I think. So I think with that soft tissue envelope for me, it would have been either, you know, cast or fixator or you know, certainly fusion is an option. I think the questions come up about if you're going to fuse, like what's the best implant to use. Ideally, you spare the subtalar joint, and that usually means since you have to span a fracture and fuse a joint, you can't just use screws. It usually means some sort of plate that spans the fracture and gets fixation into the talus. You know, they make some plates now that can do that are long sort of anterior fusion plates, but I'm not sure that they're very widely available. A posterior blade plate fusion is another option. It's a lower cost implant and is a little more soft tissue friendly actually when you have a challenging soft tissue envelope. But I still think that would have been this case would have been very difficult, I think, for a primary fusion with plate just because of the soft tissue envelope, unless the posterior skin was really good and you did the blade plate option. And the nails, I think, are kind of like, I don't want to say they're a last resort, but they are, I think I would reserve them for cases where you really don't have other good alternatives. Because you're taking away the subtalar joint and the ankle joint, which does compromise quite a bit of foot motion. That being said, I think, you know, this was well executed. It's a powerful, you know, it's a very powerful tool for getting the metaphysis to heal because of you get really, you know, robust intramedullary fixation. So it does reliably work. One of the questions I had for you, Fasi, is kind of what you did with, you know, joint preparation. I think that's one of the controversies maybe in the scenarios. Do you prep the ankle on the subtalar joint? And how did you decide about that?
Yes, it's a hot topic these days about these fractures. Whether if you're going to do a retrocalcaneal nail, would you prep the ankle joint or not? I personally don't do it. This one, and secondly, there's again a question about if you have to prep a joint, whether you do prep both the subtalar joint as well as the ankle joint. So in the case of fracture, so you then have three interfaces: the subtalar joint, the ankle joint, and the fracture itself, and then it kind of becomes quite complicated for all of the three to heal. So definitely don't do the subtalar joint. Ankle joint, I did not do it in this case. This was my very first case 5 years back. If I had to do this case today, yes, maybe I would have prepped the ankle as well, and because I did add bone graft, so opening site, prepping the ankle, and then putting graft would have been a much better option.
Thank you.
But even
I think
in this case, 5 years out, he doesn't have any pain, and although he doesn't have motion, but he also doesn't have any pain.
Yeah, I mean, I think the key thing is that you gave him a plantigrade foot, you know, a stable plantigrade foot and a healed soft tissue envelope. And that is like, if there's any one thing that will help a patient have good function, that is it. But yeah, there's interesting data from the SIGN database where they've looked at sort of, you know, whether people prep the ankle or the subtalar. And although, you know, the rate of fusions may be a little bit higher when you prep, the actual, you know, doesn't seem like there's a big difference in functional outcome. I personally, for acute fractures, when treating it this way, I've kind of gone away from definitely not prepping the subtalar joint. I think the ankle is a little more controversial. If it's a really horrible soft tissue envelope and really blasted joint, I think you can often actually get away without prepping. But if it's established arthritis or something like that, you probably should definitely prep the joint for a robust fusion that will last.
I think Fernando will also comment a little bit on this idea of prepping versus not prepping in his next presentation, which I'd love to get to in our last few moments as well. But Justin, since you've got your hand up, please do make your comment.
Yeah, just quick comment. Agree with everything Dave said about this problem. Looks like you did a really nice job of salvaging this leg for this patient, and agree with Dave that I usually try to avoid hindfoot nails in this population just because I've done this several times, and the patients really aren't happy with the end result in terms of their range of motion and mobility. And so an alternative potentially for this one, because you are dealing with more of a metaphyseal issue, is to do an antegrade nail that just goes into the talus. It is a little bit more short segment than obviously what you did, but it is a reasonable alternative that works pretty well, and could have used the sign nail. Just something to consider for if you ever have another one of these situations. But yeah, overall, really nice job of salvaging this leg for this patient.
That's a great point, Justin. We'll have to have you present a case like that if you have one at one of our other case discussions, because I've never seen someone do antegrade into the talus. It's really smart. Fassi, I'm sorry to cut this short a little bit, but we'll still talk a little bit more about fusion after Fernando's case. If you don't mind, we'll stop sharing and invite Fernando to talk a little bit about his approach to fusion, because I think it's an important salvage option, especially in resource-limited settings.
I believe you all can see my slides, right?
Yes.
Okay, perfect. So thanks again. Thank you so much, Kieran, for the invitation. You're like, working with you is inspiring for me, as you all know, man. Anytime you need anything from me, I'll always be there to help you in any way. So this is this 83-year-old lady, a little bit different case because a little bit of a different patient, right? She fell downstairs carrying a table, and then she fell like 7 stairs down, and she had pain on both ankles, right and left. The left ankle, she had just a small, simple Weber B non-displaced fracture, but the right ankle, she had a lot of hematoma. She had blisters all around the soft tissues, and she couldn't walk at all with deformity. She's a diabetic patient, even though her monofilament test was normal, but she's a diabetic patient, hypertension, irritable bowel syndrome. There's something else going on. It is like 83, very nice, very savvy, by the way, lady, very smart on top of everything, but she had a bad injury. Pain on the right ankle with moderate varus deformity. Skin was intact, fascia was intact, but she has a lot of blisters. The soft tissue envelope was really damaged. And these are the initial x-rays that I got. So only with the splint on, and these are the CT scan images. So if you look at the bottom on the actual view, you see that she had a good chunk of the anterolateral ankle joint that was detached. So she has the anterolateral process that is detached. She has anteromedial. Posterior mal is also off. And then you look at the coronal view images, you see how the anterior and the coronal part of the joint is subsided in the tibia, right? The tail is intact, but she has a bad comminuted with bad soft tissue envelope fracture. So now, somewhat similar to all the x-rays and images that we have seen here today, but this is again, an 83-year-old diabetic old lady. So for this type of patient, my plan was put a patient supine position. I always use large C-arm for these cases. I do prep the joint, so I have my tools with me. So I have the MIS burrs. Maybe they're not available all over the world or in all practices, but you can also use, for example, drill bits from small fragments or from large fragments, ankle fracture sets and plates and stuff. I do use kerats and osteotomes, so the joints are not prepared only with the burrs, they are also prepared with the other tools. I always put a bump under the hip so the toes are positioning perfectly to the ceiling, so I can have a good notion of rotation of the ankle to put the foot in a good appropriate rotation. And just remember always the entry point according to the nail that you will have. So this is what I had with me. I had this nail that has a 5-degree valgus on the bottom. So the patient was like laying down, and you see how the talus is anteriorly dislocated. So I put a bump right here. Put a bump here on the back of the ankle, and then I could slide the foot backwards, and then I could put the talus right under the tibia. Then I just drove the pin all the way in. On the AP view, you can see that the pin is going toward the medial cortex, which in this case, for this specific implant, is desirable because this nail has a 5-degree varus, like I said. Wait, yeah. So this is the final answer. This like the images on the left are like 2 to 3 weeks post-op. The ones on the right are like 6 months post-op. So the nail goes in with the valgus. I don't have to resect the fibula, for example. I prep the joints with only 1 or 2 teeny tiny half-centimeter incisions. So I use all the tools that I said. Curettes, they have to be curved as well, so you can prep the back part of the talus. For example, you do plantar flexion of the ankle, so you can prep the back part of the talus and also the tibia. And then with a very tiny, small sinus tarsi approach, I use the MIS burrs, the curettes, and the osteotomes to also prepare the subtalar joint, and then throw the nail in. So this is the final results. She healed nicely. She did not have any wound complications, even though she had a very bad start. And that's the case that I had to present.
Thanks, Fernando. I think the approach that you've given of the MIS, even without MIS specific burrs in a resource limited setting, oftentimes we still have drill bits and curettes. One key thing is you need to have fluoroscopy, obviously. And I think in cases, just generally speaking, you need fluoroscopy. Of course, I think if Sartak and Subhash are on the line, I wonder, did they have fluoroscopy when they were doing their cases, or does that also guide having like large, big approaches? But I think like if you're trying to deal with very bad soft tissue, this MIS approach of trying to prep the joint to get a reliable fusion is very handy. So Fasi, I wonder if you have any comments on that, if you've ever tried to do something like that.
Yes, it's a very nice case, and I agree. If the in this case there was, because of the various comorbidities and IBS and other cases, patient would also be using steroids, and also the joint is also not that great. So in this case, primary fusion would be a better option compared to fixation. Again, even at Sign, we had a discussion a lot about whether you want to prep the joint or not to prep the joint, because of the cases that we have, like the number of case series we have, there's not much difference in patient outcome at the end with if you prep the joint or you don't prep the joint, although the radiographic outcomes are different. If you prep the joint, you do get a very good, robust callus formation and healing at a year afterwards. But even if you don't prep the joint, the patient at most of the cases don't have any pain. But if ideally you have to prep the joint to get a robust healing.
Thank you. Dr. Woolley, you had a comment?
Yeah, that's a great case. I think one question that comes to mind in doing fusion nails, especially in limited settings where you don't have fluoro, is it reasonable to wait? I know that you already know what the plan is, you know the outcome is, you know what's going to happen anyway, as far as the outcome of these patients. And so two scenarios that happens in my settings, in both of my settings. One is you get these cases 3 months out, then it's already a fusion by definition, but you already have the swelling is down, the skin is better. If the patient has comorbidities, you have time to tackle that before you go into the actual surgery. And the second is if it's acute and it just came in, and you have something like that and you wanna go straight to fusion, is it reasonable to wait or not? So that's a question for everybody in their own setting. And then the other question I would have is, what about bone grafting and if you have a big segmental bone loss or you have a lot of bone defects, and you are in a limited setting. So that's an open question for everybody, whether it's high income country or low income country. What is your thought process on it? Because sometimes you have such a big defect that even if you put a fusion, you don't have enough bone graft to kind of compensate. So open for discussion.
Well, I'm happy to take on a few of those. So, I think that waiting, I I I I don't like waiting for this because she is like an old lady, and then going through 2 periods of a long non-weight bearing status is not easy for these patients. So if you wait now, she's going to be non-weight bearing for about, like, let's say 2 to 3 months, and then in a year and a half or 2 years, she's in a lot of pain, and that she's going to need the fusion. So she'll have to go through another long non-weight bearing period. So that's why I believe that doing this acutely is also a great solution. Regarding the bone graft, of course, for this case specific, I don't think it's necessary because the metaphysis, even though there's this subsidence, I don't think that's so bad. I think the case that we saw, I think the cases from Nepal and the other ones were even worse. I know that one of us here said that they're not very worried about putting graft in the metaphysis because it usually heals. I think it's true; it really does heal. But I don't like seeing a screw in the bone with no in the metaphysis without bone around it. And I grew up in Brazil. I did all my practice in Brazil for many years. We also did not have bone bank in Brazil, and I used to get bone from the iliac crest like all the time. And I know that if you have the bone graft, if you have the bone bank, is easy and there's no morbidity. But after 2 to 3 weeks, the pain on the iliac crest gets way better, and getting bone from the iliac crest is not so bad. I know that we don't do that in the United States, but all across the world, we do it all the time. It's a great quality bone. And you also have to remember, you can also get bone from the proximal tibia. You can also get bone graft from the calcaneus. So we have other sources than not only the iliac crest. So I have a lower threshold to go to the iliac crest because, like, biologically speaking, is better than allograft. And I try to feel some. If I have a large void, I would fill it with bone graft from the iliac crest.
Great comment, Fernando, as usual. Excellent. Really appreciate all the discussion. We are a little bit over time, and I appreciate so much that we have almost 150 people who are still here with us. Just as we transition to the end here, I'll invite all the faculty to maybe make some last final comments. And oh, Bonnie, please. Bonnie, you've got your hand up. Would you like to say something?
Hi, everybody. Thanks for the honor to be a part of this, and always learning from everybody too, really. So this is more of a general comment, not specific to any particular case. And my background is as a foot and ankle orthopedic surgeon. So always thinking about the post-reconstruction and managing the outcomes of these injuries. And most of the time it's a combination of arthritis and deformity. And so one thought I just posed to everybody is for a lot of these fractures, when it's appropriate, I consider doing like a direct anterior approach. I know we talked about anterolateral, posterolateral, medial, sometimes direct lateral. And I find that through an anterior approach, you can really get to all the main pieces. And sometimes you can do, somebody mentioned like a MIPO technique, like medially, just to slide additional fixation. And then it doesn't preclude having to make a lateral incision as well for the fibula sometimes. But I find that the anterior approach is quite versatile and just something to consider. And it's the more, I think, definitive approach when you might come to needing to do future reconstruction or surgeries that need to address the arthritis, whether it's a fusion or a toe ankle replacement, which I know a lot of places may not necessarily have yet, but I think it's something on the horizon and growing. So just wanted to pose that as additional thought about the approach. Thank you.
Thanks,
All right,
Bonnie.
Go ahead, Kieran.
No, I was just filling the void of silence. No, that was excellent comments, Bonnie. Thank you. Doing that anterior approach is really smart, I think.
All right. Any further comments from the faculty? I think we're coming to the end of our session here. So if there are any final thoughts, anyone can go ahead. Otherwise, we'll wrap things up here. All right, perfect. Well, thank you everyone for a great session. I think every week we've had some really excellent cases presented and some great discussion. So I certainly learned a lot, a few new tips and tricks that I'll take back. And then I think we just have a few slides with the post-course survey and some information about the next week's session.
Yeah, thanks, Haley. I can just put in a final plug here. So thanks again to all the faculty and, of course, to Haley and Shravya for moderating the discussion. Fantastic cases, learned a lot of great tips and tricks. For anybody who attended today, please do fill out our post-conference survey. We really appreciate the feedback on these case presentations and conversations. It helps us make these presentations better and better. Please let's continue the conversation. There's never enough time in these sessions to go into all the nitty-gritty for each one of these cases. And so we've created these WhatsApp communities to really allow us to continue the conversation offline or in a different format. Opportunities here to share your own cases, those of you who are attending these sessions, and get comments from many of the faculty who participated today. And then we have a fantastic online library of resources that we've created on Sona Global Academy. Just go to sonaglobalacademy.org. I've put in a couple plugs over the course of the last hour and a half for some of the resources we have up there. There's a fantastic video from OTA shared for free to all people who've registered for our course on posterior blade plate arthrodesis, which was something that was brought up in the chat. There's a great video in there from Edward Rodriguez from here at Harvard. Full video on JOMI, step-by-step of fixing an open Pilon fracture. Great videos available on there, including all the fantastic lectures provided by our faculty. So please do check that out on Sona Global Academy. It's all free, open access for all. And thank you all for joining today. Really do appreciate another great opportunity to learn with you together. So here are the links for the pre and post conference surveys. And with that, I'll end the session. Thank you all.
Thank you.